The next speaker, in fact, happens to be the Vitiligo up and coming invited speaker. So that is Dr. Ahmed Mourad, and he's a dermatology fellow, teaching assistant at Cairo University Faculty of Medicine at Qasr Al Ani Hospital. And he's going to speak on assessment of tissue PD1 and PDL1 levels in vitiligo patients, a case controlled study. So over to you, Dr. Ahmed Mourad.
Hello everybody. Today I will be presenting our work on the levels of programmed cell death receptor 1 and its ligand in vitiligo. I have no conflicts of interest to disclose, and the study was conducted in Cairo University Hospital in Egypt. Let's start by a brief introduction to the role of PD1 and immunity in vitiligo. As we all know, vitiligo is a multifactorial disease. Of concern to our topic is the aberrant adaptive immunity that is manifested by CD8 T cytotoxic cell infiltration in periregional skin, which are specifically reactive to melanocyte antigen stimulation and able to selectively induce the apoptosis of melanocytes. There are three main signals involved in T effector cell activation. Antigen recognition is mediated by the interaction of major histocompatibility complex on antigen-presenting cells with T cell receptors on T cells. This signal can only activate the T cell in presence of a co-stimulatory signal caused by the interaction of CD80 on the antigen-presenting cell with CD28 on the T cell. This is called the co-stimulatory signal. In contrast, binding of the PDL1 on the antigen-presenting cell with PD1 on the T cell will thwart the activation process. PD1 or CD279 is a cell surface receptor that is mainly expressed on lymphocytes after their activation. It acts as a co-inhibitory molecule and binds two ligands, PDL1, which is the main one, and PDL2. PDL1 is the main ligand for PD1. It's expressed by both hematopoietic and non-hematopoietic cell lineages. It's upregulated in stressful microenvironments such as acute infection, cancer, and autoimmunity, in which it's mediated by the increased interferons, particularly interferon gamma, which is a central cytokine in vitiligo. The PD1-PDL1 pathway has differential action on T cells. It inhibits the activation, expansion, and survival of effector CD8 T cells, whereas in the presence of TGF-beta, it biases the naive T cell programming towards induced T regulatory cell development and survival. The PD1-PDL1 interaction is between two cells, hence it's called trans interaction. Another recently discovered mechanism is the cis interaction between PDL1 and CD80 on the same antigen-presenting cell. PDL1 was found to sequestrate CD80, preventing its binding to CD28 on the T cell, thus thwarting the co-stimulatory signal. Therefore, PDL1 both inhibits activation of effector T cells directly and prevents the co-stimulatory signal that is needed for their activation. Since PD1 has a differential action on T cells as it promotes apoptosis of antigen-specific effector T cells and induces development of regulatory T cells, so this effect must be regulated to keep the balance between T effector and T regulatory cells that is needed in healthy immunity, where good immune surveillance must be balanced with preserving the peripheral tolerance. In case PD1 is absent, this balance is tilted towards excessive effector T cell activation compared to diminished T regulatory function, leading to autoimmunity. On the other hand, in cancer, there is overexpression of PDL1, leading to reduced T effector cell activity and boosted T regulatory function. This reduces immune surveillance and allows the cancer to evade the immunity and spread. This is why several PD1-PDL1 inhibitors have been approved for use in cancer, namely melanoma. They act by shifting immunity from over-leniency to self-reactivity to better control the cancer. However, excessive self-reactivity can lead to autoimmune reactions that are called immune-related adverse effects. One prominent such adverse effect is the development of vitiligo-like lesions, which are characterized by an eruption of depigmented macules with confetti appearance, usually in areas hidden from the sun exposure. This picture reflects that of active vitiligo. They occur in both melanoma and non-melanoma tumors, with up to 25% incidence of vitiligo-like lesions reported in patients treated with pembrolizumab. Multiple studies have correlated the occurrence of vitiligo during treatment with favorable clinical outcome. These facts strongly point to a possible role of PD-1 in the pathogenesis of vitiligo. We can expect either reduced PD-L1 expression on melanocytes or reduced PD-1 expression on T effector T cells. Both would lead to a decreased peripheral tolerance for melanocytes. Several studies were conducted on PD-1 expression in vitiligo. Ahmed et al. Conducted a qualitative study of PD-1 expression in the skin of 30 active vitiligo patients. They found that PD-1 expression in the marginal biopsies was more than that in the lesional biopsies, and that was even more than in the non-lesional biopsies. Studies on peripheral blood of active vitiligo patients showed increased PD-1 expression on both CD8 cells and on Tregs. Studies on skin of vitiligo mice showed increased PD-1 expression on periginal CD8 positive T-resident memory cells, but that was absent in those cells within the depigmented hair follicles. That could be due to the burning out of the lesion. These results are perplexing because all of these studies pointed to an increase of PD-1 expression in vitiligo, which is the opposite of what is expected to bring about autoimmunity. However, PD-1 is one side of the story. The status of its ligand, PD-L1, has to be elucidated to see the full picture. So, we designed a case control study to quantify the level of PD-1 and PD-L1 in active vitiligo patients. We had two groups of participants, 30 patients with active vitiligo and 30 age and sex matched healthy controls. From each normal control, we took a 3 mm skin punch biopsy. And from each vitiligo patient, we also took a 3 mm punch biopsy from the margin of the lesional skin, as well as a 3 mm punch biopsy from unaffected skin at least 10 centimeters away. All the samples were processed using ELISA technique to quantify the level of PD-1 and PD-L1. We excluded patients with PD-1 associated skin immune diseases such as psoriasis, atopy, and bullous pemphigoid. We also excluded all patients with present or past history of skin cancer, since they are known to overexpress PD ligand 1. Clinical assessment included VASI score for severity and VIDA score for activity. Our patients and controls were homogeneous as regards to age and sex. The average duration of vitiligo in patients was 7.5 years. The most common variant was generalized, and the most common sign of activity was spreading of the lesions. The vast majority were VIDA 4+. There were cases of varying extent, with the average VASI being about 5. We found that the level of marginal PD-1 was significantly higher than that in non-lesional biopsies and than in control biopsies. Non-lesional PD-1 level was also significantly higher than that in the control biopsies. We also found a significant positive correlation between the level of PD-1 in marginal biopsies versus that in non-lesional biopsies. PD-1 level was not correlated with patients' demographics or clinical condition. This denotes that the overexpression of PD-1 is increased regardless of any of these parameters. Our findings are in line with the previous study of PD-1 level in the human skin by Ahmed et al. However, our study additionally confirmed that PD-1 expression in the control skin is less than in patients, both in marginal and non-lesional skin, and that there is a strong positive correlation between PD-1 levels in marginal and non-lesional biopsies that may reflect the systemic nature of the inflammation. As for the PD-L1 expression, we found that the marginal PD ligand 1 to be significantly less than both non-lesional and control PD ligand 1. Moreover, non-lesional PD-L1 was significantly less than control PD-L1. PD-L1 levels were again not correlated with patient demographics or clinical conditions. This denotes that the expression of PD ligand 1 is decreased regardless of these parameters. This is noteworthy, as the aforementioned studies did not quantify the PD ligand 1 in vitiligo. we found it to have the opposite pattern of PD-1 expression. So PD ligand 1 was significantly reduced, whereas PD-1 was significantly overexpressed. We can see in the graphs below that the lowest level of PD-1 level was that in controls, followed by the non-lesional biopsies, and was highest in the marginal biopsies. In contrast, the PD ligand 1 level was highest in the controls, followed by the non-lesional biopsies, and was lowest in the marginal vitiligo biopsies. This explains multiple phenomena. The lower PDL1 in affected skin explains the failure to control active inflammation in the marginal skin despite having abundantly expressed PD1 receptors on the infiltrating T effector cells. Also, the reduced PDL1 in unaffected skin explains why active vitiligo patients are liable to spreading the disease to distant sites. A notable murine study by Miao and colleagues in 2018 revealed significantly repressed expression of PDL1 protein in mouse melanocytes of vitiligo mice versus control wild-type mice. Administration of PDL1 fusion protein agonist caused repigmentation, inhibited T cytotoxic cells, and released suppression of Tregs. In this photo, we can see how a vitiligo mouse achieved significant repigmentation after PDL1 fusion protein agonist therapy. In light of the previous data, we propose a model of defective programmed cell death 1 signaling checkpoint in vitiligo. The broken arrows represent the breakdowns in signaling in vitiligo. First, interferon gamma producing CD8 positive T cells are known to be abundantly present in perilesional vitiligo skin. PDL1 expression in perilesional skin by melanocytes among other cells was found to be diminished in our study, despite PD ligand 1 typically being interferon gamma induced and vitiligo being an interferon gamma mediated disease. In contrast, PD1 expression was found to be enhanced in our study, possibly in an attempt to control the active inflammatory reaction by PD1 checkpoint. Diminished PD ligand 1 expression is insufficient to inhibit the autoreactive CD8 positive T cells, which normally infiltrate vitiligo. The diminished PD ligand 1 expression is also insufficient to induce CD4 positive T regulatory cells, which therefore fail to suppress the autoreactive CD8 positive T cytotoxic cells, allowing the propagation of the inflammation. A promising treatment to reverse these defects would be the use of PD1, PD ligand 1 agonists to shift the immunity back from self-reactivity towards the normal healthy state. Vitiligo treatments are still unsatisfactory. Whether they be medical or otherwise, a lot remains to be desired. This leaves a lot of room for investigating potential PD1 agonists, both in systemic form or topically with assisted delivery to mitigate the possible side effects. As regards phototherapy, UVB was found to increase PD ligand 1 in both keratinocytes and melanocytes via the stress response pathways. The diminished PD ligand 1 expression in vitiligo suggests that another suggested mechanism of action for UV phototherapy is via upregulation of PD ligand 1. Our study was limited primarily by the use of ELISA to measure PD1 and PDL1 expression. ELISA only serves as a general quantification and cannot determine the histological site nor the cellular participants involved. To wrap it up, programmed cell death checkpoint seems to be implicated in the loss of peripheral tolerance in human vitiligo. PD1 is highly expressed on infiltrating T cells, yet insufficiently stimulated due to the lack of local ligand 1 expression. PD1, PD ligand 1 checkpoint activation may succeed in stabilizing and reversing the depigmentation. Thank you for having me here today, and I thank our patients who contributed with their biopsies to these novel insights.
So first of all, let me congratulate you, Dr. Mourad. I think that was a very novel presentation, and we do keep, needing to have all these innovative methods, in the pathogenesis and novel methods of treatment for vitiligo. So it's really very important. And I'll take up one or two questions that have come. I can see that Dr. Caroline has put up her hand, but before that, there's a question in the chat box. I think it's from Dr. Ahmed, what is the status? This is to Dr. Ahmed. What is the status of PD-PD-L1 expression in lesional skin? Very nice and systemic study. So would you please take that on?
Thank you very much. In the lesional skin, we didn't test because we were expecting the burning out of the lesion could affect the results. But as I remember, Awad et al. Found that it was actually upregulated within the lesions. There was a study I mentioned in the mice that found it was actually decreased, and they said could be burnt out. So that's why we chose the marginal site, because it's the one that is most documented to have T-cell infiltration. Sometimes within the lesion, there may be no T-cell infiltration if it's progressing to stability.
Okay, so you didn't do it in your study, but it is there in the other study, isn't it?
In our study, we did the marginal because we wanted to make sure that there is a T-cell infiltration that could harbor the PD-1. PD-1 is only on T-cells or lymphocytes. Okay. That's why we were looking for that site.
Okay, thank you. Dr. Caroline, do you want to say something? I think you had a question. Yes.
I still have I'm still curious about this. I know that there's a lot of emphasis on melanocytes and how much PD-L1 they express, but I would say, it's not necessarily an antigen-specific interaction. So I'm really curious about other cells in the microenvironment that could be, that could otherwise have contributed to kind of stalling the activity of T cells, but they also seem to downregulate PD-L1, is that right? I just wanted to have your comment on, did you see a general downregulation or specifically on melanocytes in your study?
No, our study was conducted using ELISA, so it wasn't specific to cellular components. I think the study yesterday on PD-1, it was using immunohistochemistry and flow cytometry, and they found, maybe if Marcella is here, she could comment, they found that it was PD-L1 was specifically decreased on melanocytes. If she's here, she could comment on this part.
I think she was looking specifically at melanocytes, yes. Right? So that's still a little bit different. Yes. In the sense that I'd be very curious to see, maybe by immunohistochemistry or something, if anyone has any data for PD-L1 expression in cell types other than melanocytes, only because, I would imagine that they could kind of overrule the loss of PD-L1 on melanocytes if they're not contributing. Marcella also was saying, it's odd to think, that keratinocytes would also not be able to respond to interferon gamma and not upregulate PD-L1. But so it would give us some idea of mechanism, is really. Thanks, but I won't belabor this. It's just really exciting. Thanks.
Yeah, so I have just one more question for you, Dr. Ahmed. This is from Dr. Mitesh Dwivedi. What is the status of PD-1 on Tregs of active vitiligo?
On Tregs, it's the opposite of T effector cells. T regulatory cells in vitiligo are suppressed because the PD-1 is responsible in Tregs for allowing their action. So when the PD ligand 1 is not expressed, we could expect that could be the cause that suppresses the Tregs. And actually, Meow in his study on their study on the vitiligo mice, when they administered the PD-L1 fusion protein, they specifically tested for the Tregs, and they found that after he gave the PD-L1 fusion protein, this released the suppression of Tregs, and Tregs started to infiltrate the vitiligo lesions in a much greater quantity.
Okay, so I think, okay, fine. There is that's John Harris, I think, answering. So I think these are some of the questions that have come up, for your talk, Dr. Ahmed. And if there are any more, we can take them, as I do the Q&A for the poster presenters. But I should commend you, for your study. I think it's
Thank you very much.
Really a good area that you're looking at. Congratulations. Thank you.